Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. So for a patient who attended with really hard, rock solid wax and keratin, so dead skin in both ears, they are a hearing aid wearer as well, which has no doubt impacted this wax further in. The patient did use some cotton buds. You can see that there, it was hidden away anteriorly. Patient didn't advise me of that, but I could see the wool fibres there. I'm just touching the surface of this plug of keratin and wax with the suction probe, and it's so hard, there's no suction grip. So immediately I've decided to revert to a mechanical removal using ear hooks, forceps and a Keratin. So I'm trying to just glide the hook into anteriorly, so to the front of the ear canal, and then rotate the hook. But this plug is so hard and rock solid, and it's so impacted, it's so occluding, it's very difficult to glide the hook into the opening or in between the ear canal and the wax. I'm just now using the Jobson horn. I'm trying to scoop underneath this plug of keratin, trying to detach it from the canal wall. You can see you probably saw them wriggling this Jobson horn, this Keratin, trying to get in and underneath. And you can see I'm just slowly lifting it off the canal wall. It's got all these skin adhesions, which really adheres it to the canal. I'm just going back now with the hook, gliding it in. You can see me slowly rotate that anti-clockwise, so the tip of the St. Bartol hook is embedded into the wax, and I'm slowly bringing this forward whilst twisting the hook at the same time to get some purchase. Managed to remove a little bit of keratin and some wax there. I'm just going back in with the hook. Now I'm at the base of the ear canal and actually also on the back part of the canal, the posterior canal wall, and I'm just trying to glide the hook in between the canal. You have to be really careful here because we don't want to put too much pressure on the canal wall, but we are on the cartilaginous portion, so which is semi-sensitive and semi-flexible, so I've got a bit of give there. I have detached this and mobilized it now from the back part of the ear canal. I've just decided to use some forceps to bring this forwards a bit. So far we've used suction, we've used an ear hook, we've used a Jobson horn and also forceps. Now the patient has got a bit of otitis externa. Otitis externa is an umbrella term for an infection and or inflammation and or irritation, itchiness of the outer ear canal. In part it's due to the patient's age. They are quite elderly and they are prone to dry skin in other parts of the body, especially around the scalp region. And as we get older, the skin that lines the ear canal, it's less able to retain the intracellular fluid, the moisture, which then makes the skin very dry, flaky, it dies quicker, and then it can form into a plug. So we're making good progress with the forceps. However, there's a point I think now where I'm not able to use the forceps anymore because there's nothing for me to grab onto. So what I'm doing now, I'm just want to make an opening at the roof of the ear canal. So I'm just going back in with the suction, not to remove this plug of keratin and wax, but just to maneuver it lower so it allows an opening, a space, so I can insert the hook into the roof of the ear canal. You can see with that additional space I've created, I've managed to embed the hook into this plug of wax, and I'm bringing it all the way out. So you can see how dry the ear canal is. So the eardrum is visible, but I'm just going to try and peel off some of this dead skin. It did clarinet a bit, so we have to be careful. When you've got really dry skin like this, it can cause the suction probe to emit a very loud, high-frequency sound. We call it clarinetting. It's just the skin that violently flaps against the tip of the suction probe, which is going to remove some of this dead skin off the eardrum as well. There's some just at the base of the ear canal. And there is some to the back part of the eardrum. This is the posterior portion of the eardrum. We're going to actually peel it directly off the eardrum in a moment. You can see that there. Be really gentle. There's not much space to work in the patient's ear. He had a bit of a narrow ear as well. Now, me removing this is not going to improve the patient's symptoms. It's not going to make them hear any better, but it's more preventative. It's going to just get as much dead skin as I can out of the ear safely as possible. The patient was very still, they're finding the procedure comfortable, so I decided to persist a bit more. See, there's very little manoeuvrability in there. If I move, could be careful with that fine end suction probe as I'm manipulating the skin and peeling it off the eardrum. Just got to make sure that I'm not bumping into the canal wall with this suction probe. So it's just some dead skin at the roof of the ear canal and also superiorly, so to the top part of the ear. I'm just peeling that down. Again, as I'm bringing this fine suction tip down, I've just got to be careful that I don't bump into the bottom of the ear canal at the base. So I'm happy with that. It's going to mop up near the entrance now. There's a bit of dry skin flakes there, so I'm going to use a combination of suction and also a Jobson horn just to gently graze and almost scoop out some of this dry skin flakes. So just some dead keratin. So keratin is actually a protein that's found in various cells, so in your nails, your hair, for example, and it occurs in the ear as well. So as this dead skin dies and the fluid leaks out of the cell, this keratin builds up, this protein, and it can oxidize. So it starts off white, but as it's been in the ear longer, it turns into a pale yellow, then a brown, and almost like a black colour if it's been there for a while. Keratin has some properties, some useful properties. It's hydrophobic, so it helps to repel water that enters the ear. We don't want water in the ear, guys. Water is really bad. And it helps to reflect away harmful UV rays from the sun as well. So it does help provide a protective barrier of the ear canal. So the patient's left ear is done. This is the patient's right ear. Similar story. So I just went straight in with an ear hook. I thought I'm not going to use suction here. I'm just trying to roll this forward. You can see I'm using the tip of the St. Bart's here to gently just roll this forward, slowly but surely move it, bring it forward, so it enables me to then get further in and behind the plug of skin and wax. So at the moment it's completely sealed, so by bringing it forwards it opens up the top part of the ear canal where I'm going now, so I can glide the hook in a bit further, in and behind this plug, slowly but surely bringing it out. Just got to be careful as I'm bringing it out that the tip of the hook doesn't graze the canal wall, especially the bottom part of the ear canal. It's quite easy. It can happen where you're bringing this hook out and you've embedded it too deep into the plug of keratin and wax, and the tip grazed the bottom of the ear canal and you can quite easily scratch it. There we are, it's come out a big mass. So there's the patient's ear. You can see some blistering there at the back. That's where this because this plug of skin and wax is so dry, and so there's skin adhesions. As I extracted it, some of the skin came off the canal wall and it's just caused a blister. That's not going to cause the patient any problems. So I'm just using the fine end suction probe now just to peel off some remnants, residual dead skin around the more laterally on the cartilaginous portion. So we can put a bit more pressure here. I just block the suction probe, so it's going to go in and out. If you keep watching, you're going to see some close-ups of these keratin and wax plugs. So I'm going to hover over it using the endoscope so you can have a close-up view. Do stay tuned, guys. I've got some really, really exciting videos coming up. I've had a busy day today and a lot of the procedures are quite, I feel, educational and interesting. So I will upload them in due course. So this is at the roof of the ear canal near the entrance. Just peeling it away. Patient could hear significantly better. They actually wear hearing aids, as I mentioned right at the beginning, and because of this dead skin plug and wax, it's causing their hearing aid to feedback, to whistle, so the sound that we're amplifying into the ear is hitting the wax, reflecting back out to the ear, re-entering the microphone, causing feedback. So I hope you enjoyed that video, guys. Take care and speak soon.